Good afternoon to everybody. I would like to focus on our own experience on the high risk of population with non-muscle invasive bladder cancer. But first of all, I would like to focus on two important aspects. The first one is the dedicated uropathologist. So the results I will show thereafter must be read according to this observation, because in our department all the patients underwent, performed the urinary cytology and simultaneously the EpiCheck analysis. And we rule out all the patients, all the urinary cytology coming from other hospitals, other private analysis groups. This is an important point, because I think that just to answer to the previous colleague comment, to understand that the performances of both tests must be heralded when we have only dedicated people. The second aspect is related to the patient population we submitted to this presentation, to this analysis. These are patients with high-grade tumors, and we focused particularly on the patients on follow-up. As you can see here, the major part of the patients are on follow-up. That means that these patients have been previously treated with the BCG therapy and were in maintenance treatment with BCG. This is an important point, just to give you an idea of what I would show you thereafter. As you can see here, there is a linear correlation between EpiCheck score and the results, but this may be obvious. Here, the overall results. The overall results show undoubtedly that the EpiCheck is superior in terms of sensitivity, specificity, and negative predictive value if compared to the urinary cytology, and underline again, performed by a dedicated uropathologist. So these data are absolutely coherent with those previously presented by the other authors. What I would like to focus is this aspect about the patients on follow-up. As you can see here, the patients on follow-up has a sensitivity of 77% with a negative predictive value of 85%. What does it mean? Breaking down a distinction according to the patient characteristics, you can see here that the value, the performances of the cystoscopy were inferior if related to the EpiCheck in patient on follow-up. This is an important point. These data are coherent, as I told you just a moment before, with the data previously presented. But personally, I was surprised about this data. And breaking down the distinction, this is the predictive value, as I told you. If you look to this aspect in patients with carcinoma in situ, you can see here that undoubtedly in the first diagnosis, endoscopy, EpiCheck, and cytology are give us for its own information. What is important to underline is that in the patient on follow-up, it means that this patient had TIS, carcinoma in situ. They have been treated with BCG, and they are followed up with urinary cytology and EpiCheck. We can see that the performance of the EpiCheck is undoubtedly higher if compared to the cystoscopy. And this aspect has been shown also in patients with T1, as well in the small cohort of the patient with TRG3 disease. What does it mean? Coming back to the T1 patient, this data must be related to a precise observation. These patients recurred 6 months later with a T1 or TAG3 or TIS. In other terms, the cystoscopy was negative, apparently negative, but the EpiCheck was positive, and the most stupid conclusion is that EpiCheck is able to anticipate the onset of a tumor. This is an important aspect that we must see here in a small proportion, in a small number of patients, but in my personal opinion, it could be a very, very important point to be focused in the future studies. As a consequence, my conclusions are expected valuable diagnostic performances, better than cytology, also in a referral center. And undoubtedly, we must evaluate in a very controlled studies what is the cost-benefit ratio, but it depends on country and country, and if we can undoubtedly decrease or replace the cystoscopy. Last but not least, we can evaluate what is the anticipatory value of a positive EpiCheck test in predicting the onset of a new tumor in patient in follow-up for bladder cancer. Thank you.
Thank you very much. Okay, Pier Francesco, so you confirm the results that we have found in the bigger studies. That's great. You even found some predictive value for future recurrences. That's even more great. Would this be something that you are going to use in your practice, depending on cost, etc., and the logistics, to reduce the number of cystoscopies? Is something you could consider?
I consider this option absolutely possible.
Okay,
Could
great.
Be undoubtedly the next step.
Great. Any questions for Professor Bassi? Okay, Pier Francesco, thanks very much. Good work. Keep it up.